So as you can see, we have the pleasure of having L Roszko as a speaker. She's an adult endocrinologist at the National Institutes of Health. Her research interests center around disorders of mineral homeostasis, which include diseases of altered FGF23 metabolism and hypoparathyroidism. Her main focus is on hyperphosphatemic familial tumoral calcinosis, or HFTC, that you'll hear much more about today, a disorder of FGF23 deficiency that results in high serum phosphate levels and ectopic calcification. Her interest in bone and mineral metabolism began during her MD PhD training at Connecticut. She initially studied hyperparathyroidism and completed her PhD under the mentorship of Dr. Andrew Arnold. She then completed her internship and residency in internal medicine and then fellowship in endocrinology at Mass General and Harvard in Boston. There, with the mentorship of Dr. Michael Manstad, she focused on autosomal dominant hypocalcemia type 2, or ADH2, creating a mouse model of the disease and testing new treatments for it. She then moved to the lab of Dr. Michael Collins at the NIH, or NIDCR specifically, and now she's leading the mineral homeostasis unit as a Tenure-Track investigator at the NIH. She's pursuing both projects, the hypoparathyroidism and HFTC projects, in the basic science of calcium and phosphate homeostasis, and in translational medicine, with the goal of bringing new treatments to patients with rare disorders of mineral metabolism. In addition, Kelly is a longstanding collaborator and friend, so I'm very happy, and we're all very glad to have you here, Kelly, so please take it away.
Great. Thank you so much. Thanks for the wonderful introduction, Carlos, and thank you for the invitation. I'm really looking forward to speaking to everyone today. So let me share my screen. Let's see. Great. I'm assuming if nobody's going to say that they can't see the screen, that the screen is now shared.
It looks good.
Perfect. Okay, great. So thank you again for having me. Here are my disclosures. So today, for an overview, I'm going to be telling you a bit about the pathophysiology of hyperphosphatemic familial tumoral calcinosis, or HFTC. Then I'm going to tell you about clinical findings and how we've used those clinical findings to lead to mechanistic hypotheses. I'm going to tell you about sodium fluoride PET CT scanning and how we've used that to characterize disease. And then I'm going to go over some of the unanswered questions that we have in this field and some future directions that we're really hoping to pursue. So hyperphosphatemic familial tumoral calcinosis, HFTC, is a disorder which can present with these large tumor-like growths of abnormal calcium deposits. And you can see here the debilitating calcifications around this man's shoulders, as well as here you can see these calcifications around both lateral hips here in this 3D reconstructed CT image. So as the name suggests, HFTC is inherited in an autosomal recessive pattern, and these patients present with these high blood phosphate levels. So mechanistically, HFTC is a disease of deficient FGF23 signaling. And so we'll talk a bit about FGF23 signaling for those who aren't as familiar right now. So FGF23 is a hormone. It's made by bone cells, and it circulates throughout the body, and it acts as the kidney. And in the kidney, it binds to the FGF receptor 1 and its co-receptor Klotho here. Upon binding and signaling, it decreases the expression of NaPi2A and the expression of 1-alpha hydroxylase here at the kidney. And these things are going to lead to decreased serum phosphate levels and a decrease in serum 125 vitamin D, which is that active form of vitamin D. In the case of FGF23 deficiency, NaPi2A and 1-alpha hydroxylase are going to be inappropriately expressed here. And then there's going to be a decrease in the urine phosphate excretion. And this decrease in urine phosphate will lead to a resultant increase in the serum phosphate levels and in that active 125 dihydroxyvitamin D levels. And this tends to lead to these types of lab values, which we see in our patients here. And as you can see, the calcium, it tends to be in that high normal range. the phosphate tends to be frankly quite elevated, and the calcium phosphate product that you can see here is also elevated. And this is all likely one of the drivers of formation of calcifications in these patients. And in many of the patients, the FGF23 levels are going to follow this pattern that I've pictured here. So you can see the intact FGF23, which is the active form of the hormone, is very, very low, almost undetectable, while that C-terminal FGF23, which is including breakdown products that are inactive of FGF23, can be really quite elevated in many of our patients. And so let me tell you a tiny bit about FGF23 circulating in both that intact and biologically active form and the C-terminal or inactive form. So the secretion of intact FGF23 is dependent on this post-translational modification of the hormone. So when FGF23 is produced inside the cell, it's glycosylated by an enzyme called gallant T3. And this glycosylation, represented by these yellow squares here, stabilizes it. And then FGF23 can be secreted in its full-length, active, and intact form. However, if gallant T3 is not present in the cell or not functioning properly, FGF23 is not glycosylated, and it's readily cleaved by a proprotein convertase that's called furin into its inactive C and N-terminal fragments. And then, as I told you before, this lack of FGF23 action at the kidney ultimately leads to phosphate retention and increased conversion of 25D to the active 125 dihydroxyvitamin D, both driving serum phosphate up. So the loss of FGF23 action in the cell is actually most commonly caused in over 90% of the cases of HFTC by pathogenic variants in gallant T3. And that is what leads to that lack of glycosylation and the breakdown into its inactive fragments. This disorder can also be due to mutations in FGF23 itself, and this is usually in less than 10% of the cases. And rarely it's been described due to mutations in Klotho or the FGF receptor 1. And finally, in our lab, we have also described one case that was due to autoantibodies to that FGF23 hormone. So now that we've gone over a bit about the pathophysiology of FGF23 homeostasis, I'd like to jump to the clinical findings in our patients. And I'm going to tell you how those clinical findings have really led us to looking for mechanistic hypotheses in this population. So currently, we have 24 patients in this cohort. This makes it the largest well-studied cohort of these patients in the world. And these patients range in age of presentation to us from infancy all the way up to 74 years old. The majority of them have mutations in that gallant T3 gene that I told you about. And then we also have one patient with a mutation in FGF23 itself. And 4 of our patients have other or unknown causes that we're looking into now. So dental calcifications are actually the most penetrant feature of this condition, and I'll show you more in depth these short bulbous roots and pulp stones that can form. The vast majority of these patients develop soft tissue calcifications, and these calcifications can grow quite large. They can impede the movement of hips, shoulders, and elbows, and they can even break through the skin and weep what we've been calling sort of a milk of calcium. And that's essentially a liquid hydroxyapatite. Vascular calcification that you can see here in the femoral arteries is also present in over half of the patients that we've been studying, and it can cause significant complications, including amputation. And finally, inflammation, as represented by an elevated CRP or C-reactive protein, which is a biochemical marker of inflammation, can be found in about half of our patients. And you can see that in histology of these large foamy macrophages that are actually ingesting calcium deposits there. So, first, I'd like to start with a deep dive to tell you a bit about that dental phenotype, which, as I said, is the most prevalent phenotype in 95% of our patients. So, this is the representative picture of the dental phenotype of our HFTC patients. This work was done by Alyssa Lee, who is a dental student that worked with our group, and she created a schematic diagram here that you can see illustrating the system that we decided to use to score the dental severity of patients with HFTC. So you can see here a normal tooth. This has healthy pulp, really without any calcifications inside. The mild phenotype here has partial calcification of the pulp, but with an unaltered shape of the root, so still a normal root shape. We describe the moderate phenotype as starting to show some root bulging, and then showing in here this pulp calcification. And finally, the severe phenotype. And this shows a shortened thistle-shaped root with extensive pulp calcification here in the middle. So in panel B here, you can see perioapical radiographs, and these are of the mandibular incisors showing that tooth phenotype. And it's ranging here from normal to mild with a little bit of calcification, moderate where you see some bulging and calcification, and the severe with that shortened thistle-shaped root right here. And below it in panel C, you can see perioapical radiographs from a single patient. So this is the same patient of tooth number 30, 9, 6, and 21 here. And this is really representing this large spectrum of disease just in a single patient, where you have some roots that appear to be pretty normally shaped all the way down to these really thistle-shaped and shortened roots, all in just one patient. So this figure is showing some micro CT analyses, and you have these normal control teeth in the first 3 panels, and again here in the fourth control tooth is over here. And you can see how these teeth teeth from HFTC patients have sort of a shorter, more irregular root surface than in the normal teeth. And part B here is showing micro CT analyses with 3D reconstructions and then segmentation, and you can see the control again versus the HFTC. So the white part of these teeth represents the enamel, the gray is representing the dentin or cementum, and the pink is actually showing that pulp area. And you can see here in these pulp of the HFTC patients, the pulp volume is quite reduced, and the calcifications you can see is the absent pulp spaces there. Part C is going to show the longitudinal cross-sectional heat maps. Then they're showing differences in the density distribution across these teeth. So the color is representing increasing density that goes from green to purple, which would be the most dense. So in the FTC teeth, you can see that the dentin and cementum layers are actually indistinguishable as compared to the regular teeth. And these yellow areas are showing the areas of high density that are found toward the periphery of the root in the control teeth here. But in the HFTC teeth, you can see with the white arrows that high density really right in the core of the tooth. So you can see that the density patterns in these teeth of HFTC patients are really quite different than those normal control teeth. And this is a panoramic radiograph of a patient with HFTC. You see the arrow showing those short bulbous roots with the pulp obliteration here, and the arrowhead again showing pulp obliteration in that tooth. And here you can see the percentages of all the teeth that are affected across all of the patients that we were able to study, with the red representing the most severely affected, followed by the yellow, which is moderately affected, and the green, which is just a mild phenotype. And so as you can see here, premolars really are the most affected teeth in this disorder, followed by the canines, molars, and then the incisors. And just a final figure to sort of nail this home, you can see the mean pulp density that's 7 times higher in the HFTC teeth than in control, and the mean pulp volume, which is lower in these teeth than the control. So that goes over the dental calcification phenotype, and now I'm going to move into the soft tissue calcification and tell you a bit about that in our patient. So soft tissue calcification was present in 86% of our patients. And here are some representative pictures from some of our patients. And this you can see in panel A is really one of our most severe patients. You can see calcification here on the shoulders, bilaterally, really getting into the joint spaces and impairing movement. You can see that also here in the hip, really impairing movement in the joint space. You can see calcification up here in the aortic root, as well as in the mitral valve area. And this is really interesting. You can see actually colonic calcification here. And when I first saw this, I thought, oh, I didn't think we were doing a contrast CT for this patient. But in reality, this is a non-contrast CT. And you can see that the colon is actually calcified. And this is shown here in panel D of a colonoscopy. You can see the calcification here in colonoscopy on this patient. This is an elbow calcification. You can see the radiograph, and then you can see it sort of breaking through the skin. And as I told you, weeping that liquid that can happen for these patients. And finally, here you can see some of these chest wall lesions that are really showing these fluid levels. And you can see again that fluid can actually be discharged from these lesions. This is a cardiac CT of a severely affected patient. And in panel A, you can see calcification of the LAD here on the first scan. And this is a scan that's 3 years later. And indeed, this calcification has increased over the course of 3 years. So something we really need to watch out for and screen in our patients and make sure that we minimize their cardiac risk factors. And panel C here, you can see calcification of the posterior medial papillary muscle. And this actually did stay stable over 3 years, but we did indeed see progression of the LAD. So we've been characterizing the locations of these soft tissue calcifications, and we found that the most of them here are at the hips. So these larger circles are representing greater numbers of calcifications across our patient cohort. So most of them at the hips, then also some at the shoulders, and also here at the elbows. And we also had some patients that developed this really unique pattern of subcutaneous calcification in the lower extremities. So interestingly, one of our patients developed very pronounced calcifications of the thumb. You can see that in the picture here. And we found out she was actually an avid bowler. And so bowling all the time, she had actually developed this calcification here of her thumb. And these were some of the hips here. And we started to think to sort of develop our current hypothesis about how these calcifications form. And we think that the calcifications are actually forming in areas of pressure or repeated trauma. So the hips and shoulders being affected in patients who sleep on their sides, the elbows from pressure or microtrauma from leaning on elbows, lower extremity calcifications, we think might be due to venous insufficiency, especially in a patients who have carried pregnancies and have described edema during pregnancy. And we think that inflammation and hypoxia might play just a major factor in this. So we're currently working with our mouse model to try to elucidate the mechanism of formation of these calcifications. And this is just another slide showing in panel B here, you see the lesion volume at each different area here and a wide range of lesion volumes. Panel C here is showing the total lesion volume per patient across 9 patients here that we had included in this analysis. And in panel D, you can see the volume, the lesion volume per lesion. And this is in over 27 lesions that we were able to look at. And I show this to illustrate that incredible variability of this disorder, where some patients are experiencing a relatively small amount of calcification, while other patients have a really large total body burden of calcifications. And it seems here by looking at all this that there must be more to the development of calcifications than just looking at this high calcium phosphate product. So much of our work now is really aimed at teasing apart the contributors of calcification, and then we're hoping to determine how to prevent or reverse them when we look across our patient population. So I'm going to move now to tell you a bit about sodium fluoride PET CT scanning and how we've been using that to really help characterize this disease and to help develop endpoints. So one initial question that we had was, what is the composition of these lesions? So we formed a collaboration with Dr. Eve Donnelly, a researcher at Cornell University, and we tested 4 different patient samples with FTIR. So there's a lower line here. This black line is representing synthetic hydroxyapatite. And then the gray line here, the next line up, is actually a bone reference sample. And then following that are the 4 samples from our patients. And you can see that all 4 samples have this characteristic peak, which reflects that they are indeed composed of hydroxyapatite. And this is significant and exciting because, as you know, hydroxyapatite is really a basic building block of mineralized tissues. So we found that this is indeed causing or building those calcifications. And with the knowledge that these lesions were indeed composed of hydroxyapatite, we then set out to use sodium fluoride PET CT scans to actually quantify the lesions. And this work was done in our lab by a stellar medical student, Aaron Shepard, who is now in the middle of his residency in orthopedics, and working in conjunction with our collaborator, Dr. Babak Sabori, who's a nuclear medicine radiologist. And so you can see here to the left a representative diagram of the structure of hydroxyapatite. And you can see the calcium and phosphate is structured around a hydroxyl group. And importantly, fluoride can be exchanged with the hydroxyl group. And this is the basis for using sodium fluoride PET scans. So we're able to radio label the sodium fluoride. It can be injected. It's delivered and diffused throughout the body. And then fluoride actually diffuses into this newly mineralized hydroxyapatite. And then, since that fluoride is radio-labeled, it gives off a positron, and we can use the scanner to capture all of those positrons and really quantify the metabolic activity of these lesions. So using this technique, we've been able to discern microcalcifications even down to the 50 micron resolution. And a very exciting thing is that we've been able to co-register these with a simultaneous CT scan. And that looks like essentially what you see here. So we're getting the density of the calcification on CT scan along with the PET. So the PET would be the image over here, giving us the metabolic activity in SUV. And the CT over here is giving us the density of those lesions in Hounsfield units. And then you can merge them and really see on top of each other what how that lesion is behaving. So here we've outlined this specific active shoulder lesion, and then we have been using software to determine the activity and the volume of the lesion. So the studies that I'm showing you here have been done manually with tracing out that lesion and determining the parameters. And this is very time consuming. And also we found that it could have some interreader variability. So we're working right now to try to create a protocol that uses artificial intelligence to help measure these lesions. And we're trying to develop an approach that uses windowing to really separate lesions from underlying bone and from normal structures. And so we hope as we develop this new method that our ability to quantify the lesions by sodium fluoride bone scans is actually going to improve and we can more widely apply this. So The ultimate goal of what we're doing is that we're hoping to use this technique to assess patients and to follow the natural history of the disease, and then ideally develop a marker that could be used as an endpoint for clinical trials in the future. And to do that, I'm also going to tell you a bit about how we've applied sodium fluoride PET scans to characterize vascular calcification in our patient population. So, arterial calcification has been found in patients with HFTC, and both small and large vessels can be calcified. But prior to much of this work, the spectrum of the disease has just been unknown. We have known that some of the patients with HFTC have even required amputation. So, it's been a very serious problem for many patients. Here you can see an MRA from a patient with HFTC, and you can see the presence of stenosis. That's here, the white arrows. And you can also see with the red arrowheads, collateral circulation. And this patient has developed quite a bit of collateral circulation here. So on the right, you can see a sodium fluoride PET CT scan, and this is demonstrating calcification of the femoral arteries on both sides. So see, you wouldn't be expecting to see these femoral arteries showing up on a sodium fluoride PET scan if they weren't actually containing that calcification. So the goal of this work was to develop a highly sensitive technique to identify and quantify the extent of vascular calcification. And we also wanted to look at its response to treatment. And importantly, as I mentioned, with the soft tissue calcifications, we would like to develop and validate an endpoint which might be able to be used in clinical trials to show a response to an investigational treatment that we would want to be studying. So we performed 8 sodium fluoride PET CT scans of 7 patients. And these patients ranged in age from 11 to 74 years old. So the study was able to capture information on vascular calcification in many young patients. And Aaron was then able to use the radiologic software MIM to isolate out the aorta and distal vessels from the rest of the image. And so in this way, he actually digitally dissected out the entire vascular tree so that there's not artifact created by the vertebra and other bony structures surrounding the vasculature. He then delineated regions of interest from the aorta all the way down to the lower extremity distal arteries on this axial plane cuts of the PET CT scan. And here you see a cross-sectional slice of the aorta, and this is showing active microcalcification, which is lighting up inside the aorta, as well as the region of interest that is drawn surrounding it. So that circle is the region of interest. And you can see why it's important to separate it out from the vertebrae here, which is a very high signal entity right behind the aorta. So this is the maximal intensity projection or MIP picture of an HFTC patient. And what we've done here is we've created these regions of interest, these colored lines, and each small colored line is representing an individual data point in which the region of interest was measured and a microcalcification score was calculated. So the microcalcification score, or MCS, was derived by calculating the target to background ratio, or TBR, of each slice. So by this equation that you can see here, each slice, you're taking the SUV of the target divided by the SUV mean of the background to get that score. And Aaron wrote programs using MATLAB to map the arch of the aorta. So he determined data points that you can see in these figures here, and then he drew vectors to really map the arch around each of the data points. And then slices were made perpendicular to each vector that you can see drawn here in part G. And this was really able to increase the accuracy of the technique as we tracked around the arch of the aorta in each individual patient. And perhaps here one of the most important contributions of this work is the development of what we call a vascular atlas. So we anatomically separated the vascular tree into different segments of vessels and mapped each patient to the atlas using these consistent landmarks that you can see with the dashed lines. This vascular atlas allows us not only to compare people over time as they grow, but more importantly, we can also compare specific vascular segments of people of different sizes. And here are the results of two patients. So we have one patient here who's very mildly affected in part A, and in part B, we have a patient that's more severely affected. And you can see that the patient here in part B has this microcalcification score that exceeds 4 here at the abdominal aorta. But the patient in part A has a microcalcification score that barely exceeds 3. So through this method, we've been able to assess microcalcification score and also look at different patterns that might appear across the population, across different vessels. Here are the results of all the patients that we were able to look at in our first analysis, and they're graphed using the vascular atlas here on the x-axis and the microcalcification score on the y. So on the x-axis, we have that standardized atlas showing the length of the aorta and the distal vessels with dashed lines here to represent transitions between the arteries. And this is as if the patient were laying down with head here and feet here at the bottom. And on the y-axis, as I said, we have that microcalcification score. So the gray shaded area is representing a control patient, and each colored line represents a different patient with their age listed in the legend to the right. And as you can see, the FTC patients, especially the clinically active patients, had microcalcifications greater than the control patients. And additionally, it's possible that there's a difference in the distribution of those calcifications in our patients, with a tendency to have higher microcalcification score in the distal femoral arteries and maybe in the distal abdominal aorta, where you can see these peaks on the graph. So importantly, we actually had several children in this analysis with an age range beginning at 11 years old. And we were indeed surprised to see vascular microcalcification in some of our pediatric patients. So the knowledge that a calcification can occur even at these very young ages is now shaping the way that we screen and monitor our patients. So we believe that the analysis by sodium fluoride PET scanning is so important because PET imaging is able to quantify metabolic activity of active versus inactive lesions. For instance, here you can see the Hounsfield units showing calcium density by CT in the blue on this axis, and the SUV showing that PET activity in red. And in the circle here is a lesion that's seen on CT, but it's not active on PET. So you can see here the Hounsfield units are showing the density present, but no activity. And we decided to characterize this as a metabolically inactive lesion. So as I mentioned, our goal here is to see a response to treatment and determine potential endpoints for a future trial. And we think it's very unlikely that these well-established inactive calcifications will change with treatment. Therefore, including them could actually dilute out our ability to demonstrate treatment efficacy. So using sodium fluoride PET scans, we can continue studies of just these actively calcifying lesions that might actually have a better chance of being modified by treatment, thus helping us to really see our endpoints more clearly. And we were very excited to see that we could indeed use sodium fluoride PET scanning technology to monitor the response to treatment in one of our patients. So this patient is a 53-year-old woman with HFTC who had extensive vascular and soft tissue calcifications and extensive inflammation. So her CRP here was 44, which is over 4 times the upper limit of normal, that is less than 10. So she was treated with anakinra, an IL-1 receptor antagonist, for 15 months. And you can see here that her CRP decreased from 44 all the way down to 5.9 into the normal range. And her phosphate was actually unchanged, 5.8 to 6.7. So no change there. But you can see that her baseline sodium fluoride PET scan, which is represented here in the red, showed marked elevation. And then after treatment, her post-treatment scan, which you can see here in the blue, shows an actual decrease in microcalcification score. So this is really exciting to us, as it shows that sodium fluoride PET CT scans might actually be able to act at that as a biomarker there and detect subtle changes if we were designing a future clinical trial. So obviously this technique needs to be validated, and we're working on showing its utility really across our population and across other populations, and to validate that scan. So in summary of our vascular calcification section, vascular calcification and microcalcification in HFTC is highly prevalent. It can start at an early age, and it's an important therapeutic target. And this technique might be applicable to other diseases of ectopic and vascular calcification. So especially for this community, I know we all study many rare disorders. I really would love to stay in touch and see if these techniques can be applicable to the other diseases that we study. So finally, I'm going to take just the last few minutes here to go over some unanswered questions and some future directions that we have about HFTC and our cohort. So I'm coming back to this picture that I showed you, and I'm really coming back to this just to remind you of that huge amount of phenotypic variability, both across the sizes of lesions, where lesions are really different sized across the patients, as well as the total volume per patient, which is really varied across our cohort. So why is that phenotypic variability happening is really a huge question of ours. So what causes this huge degree of difference between patients? And here are some studies that I pulled out some lab results, and these are from two brothers. And these brothers have the exact same genetic variant in GALNT3, and they both have elevated phosphate levels. And in fact, this second brother here has higher elevations in phosphate and in the calcium phosphate product than his brother here. However, the first patient has these massive, debilitating calcifications, and his brother was actually asymptomatic. So his brother came really just to help him get to the clinic visits with us. And we then did these dental x-rays. We found he indeed did have dental findings on x-ray. And when he did his labs, that we found that he did indeed have that high phosphate level. So this really supports what I had mentioned, that the elevated calcium phosphate product seems to be necessary, but really not sufficient to cause calcifications. And a large part of our future work here is really going to be aimed at understanding the mechanism of calcification formation and the reasons that we have this type of variability, so that we can really try to go back and prevent calcification formation. So I'm going to end by speaking a little bit about the current treatment of HFTC. So as you know, this is a very rare disorder, and so there are no real good defined treatment regimens. The treatment options that we use are mostly focused on decreasing serum phosphate levels. So patients are placed on a low phosphorus diet. This is really difficult to follow, as many of you know. Phosphorus is present in high parts in most foods, including proteins and dairy. We do really try to have them avoid packaged foods due to that high amount of preservatives and phosphate that's located in packaged foods. So we aim to decrease the phosphate absorption in the gut. We do that with phosphate binders, and these need to be taken really with every meal and with snacks. So it's a tough regimen for the patients with a high pill burden. We also try to increase phosphate excretion in the urine, and for that we use medications such as acetazolamide and probenecid, and these are given twice a day. We have tried topical sodium thiosulfate, and we've had varied responses in our patient population. I've shown you some data with anti-inflammatory drugs, which appear to really be helpful when the patient has that high level of inflammation, those high CRP levels. So we have had success with that. And surgical debulking. At this point, we are really only recommending surgical debulking if our patients are having functional impairment or severe pain. And this is because we've seen that some of these lesions can actually regrow. So this is some data that's caused us to try to avoid surgical intervention. And this is really data in one patient. So this patient had 4 lesions, and they're followed by CT scan over time. And the years here are graphed on the x-axis, while the lesion volume on the y-axis. And these asterisks here represent surgical intervention on the right elbow and on the left hip. So as you can see, the lesions appear to grow faster after surgical intervention. And this pattern has been seen in a few patients and has thus prompted us to recommend really avoiding surgical intervention unless it's necessary to prevent functional impairment. That said, we do have patients that have had surgery and have had good outcomes where the surgery is essentially curative to that lesion, makes it go away. We are looking into the causes that might be. And when we do recommend surgery, we're recommending really as much of a complete resection as possible. So we're in this process of studying this in our mouse model, and hopefully we can determine some effects of surgical resection in the mouse model that can be applied to help make these decisions in patients. So I'll give you now an example of a effective treatment response. This is an example of a patient who started on treatment with sevelamer, acetazolamide, and probenecid. And you can see that the phosphate, which is depicted by the blue diamonds, decreases over the course of treatment, actually all the way down to the top of the normal range, which is this shaded blue area. And the same held true for the TRP, which is depicted by the red squares, and the normal range, this pink shaded area. So after 13 months on this regimen, this patient's tumoral calcinosis that was behind the elbow here actually completely resolved. So we were pretty excited and amazed. Unfortunately, this is not the case for all of the patients. It doesn't hold true across the board. But I did mention to you how 47% of our patients do have that increased inflammation, high CRPs and inflammatory markers. So here's a patient who had high levels of CRP, and her CRP is now graphed on the y-axis here with time on the x. And we treated her with anakinra and canakinumab, which are these IL-1 receptor antagonists. And we saw her CRP over the course of the time here decrease into normal levels. And really exciting, you can see this large calcification lesion on her neck actually resolved while she was on that treatment. So that was really exciting. Unfortunately, in most of the cases of our patients, though, treatment is mostly not effective. And this is treatment response, and this is typically what we see, a more varied and more limited treatment response. So again, in this graph, the phosphate is represented by the blue diamonds, the TRP by the red squares. And this patient is treated with several agents. You can see the anakinra and canakinumab, and adding on all of these other agents over time, and really not having much of a change at all in these blood phosphate parameters. In fact, just as high, if not higher, than starting after adding all of the agents. So overall, much of what I'm showing you is difficult because we really need more knowledge of the natural history of the disease. And we need to be able to really try to assess the effects of specific treatments. And that's a lot of our work has been really aimed at better defining the natural history and identifying these biomarkers and these endpoints. Whoop. Okay. So, what are some new potential therapies? Well, we're excited to be investigating the use of NaPi2a inhibitors as a way to possibly decrease phosphate in HFTC. You can recall that FGF23 decreases serum phosphate by decreasing the expression of the sodium phosphate transporter NaPi2a in the kidney. And decreased FGF23 is an FTC. It maintains the expression of these transporters and increases the reabsorption of phosphate from the urine, increasing that serum phosphate level. So therefore, selectively inhibiting the NaPi2a has the potential to increase urinary phosphate excretion and to lower serum phosphate. So here we actually sent our GalNT3 deficient mouse model to Dr. Harold Hubner and his group, and they administered a NaPi2a inhibitor. And you see here the blue bars are representing the administration of the compound, while the red bars represent vehicle. And you can see the significantly increased fractional excretion of phosphate and the decreased plasma phosphate levels that are shown here 2 to 4 hours after administration of the drug. So very exciting potential for us. And as I said, going forward, we're looking more into whether this can indeed be an effective treatment option for these patients. So we plan to continue to use the GalNT3 mouse model, not only to help us study the pathomechanism of HFTC, but also as a preclinical model to define possible endpoints and to identify potential compounds which might be effective in our patients. So here you can see a calcification in the mouse's tongue, as shown here on sodium fluoride PET scan. It's there again in X-ray of the animal, and here is that calcification shown on autopsy. So we've spent a considerable amount of time optimizing this model and the imaging techniques to really be able to identify these calcifications. So now that we've been optimizing, we plan to use the model to explore the many unanswered questions about HFTC, including why the huge phenotypic variability, what role inflammation can play in lesion formation and in location. And importantly, we're going to be using this model of HFTC to provide a preclinical data and endpoints. And these can hopefully be incorporated into a treatment study of novel therapies for our patients in the future. So with that, thank you so much for your time. I'd like to thank everyone here from the NIH, our clinical team, as well as our research team. Of course, none of this would be possible without the patients and the staff of the NIH Clinical Center. So thank you to them and our many collaborators that I've listed here. So thank you so much.